tumor doctor, a brain tumor doctor, and an RO physician. So if a radiation oncologist is already on a kid's case, we don't want to place it with someone who doesn't know anything about them. When the patient needs to be seen or stimulated. So typically from the CT or MRI scan to plan radiation, it takes about a week and a half for a kid to get started. So if they, per protocol, or if their outcome is better if they get started within so many days of a surgery, anything like that, those are things we need to be aware of before we can adequately place those appointments. And then the previous treatments with another physician, that's if a kid has recurred. So if they had radiation in the past, now they have more spots, more areas, or metastasis to another area. If they already have a relationship with a radiation oncologist, we like to keep them with that same one. And then the last thing that we kind of consider before we ever even place the consultation on a doctor's schedule is what the doctor's patient load looks like. So if one of our doctors is currently seeing 10 on therapy patients and another physician is only seeing 5, it just makes more sense to give it to the doctor who doesn't have as many patients. So once we place that consultation with any of our 5 physicians, we start prepping for that consultation. So keep in mind that these are all things that are being done before we ever even lay eyes on a patient. So we need to identify their medical needs. Do they have posterior fossa syndrome, limiting their ability to simulate or treat without sedation? Do they have severe claustrophobia, which makes them not be able to lay on a table and get treatment without a little help or pre-medication? Is it a patient that needs their bladder filled to kind of move and shift things out of the way to treat them? Are they kids that are going to need a dressing removed for treatment every day? Things like that. So those are really important to know before we see them on that first day. Any labs needed? So do they need a pregnancy test? Here at St. Jude, our policy is that before simulation, you have to have a pregnancy test within 56 hours of your simulation if you are a female that is 10 and older. Routine labs, have they had a CBC, anything like that we need to know? Are their blood counts adequate? Do they need an IV for contrast? Are all records in the chart? Before we put a kid on our MRI scanner, we have to make sure they haven't had any surgeries that we don't have records of in case they have implants and things like that. And then early intervention. Does the patient meet requirements to meet with child life and practice before consultation? So this is something that I know that not everybody may have the resources to do, but when we simulate a kid, so do a CT and MR scan for radiation planning, they have to be in the same position that they will be for treatment every day. So a lot of times when you are sedated versus awake, your breathing patterns are not the same. So however we do their simulation scan is how we need to treat them. So our brain and spine treatments are very, very long. And so a lot of times if we're kind of borderline age, probably 9, 10, 11 years old, if we have time and resources, we try to meet with them early to see if we can't have them lay on a table, make a mask, make things a little less scary so that we can work with them and see if they will really be able to do the treatment without sedation. And then we finally reach consultation day. So this is the day that we meet those patients. Radiation oncology nursing here at St. Jude is a lot of education. We educate from the beginning and we educate all the way through. So one of the first types of education that we do is simulation education. So we go in and we introduce ourselves to the patient. So I like to say, hi, I'm Brittany. I introduce myself to the patient and their family. This isn't a trivial treatment, and I think it's very, very important to introduce yourself and kind of let them know this is who I am, this is my face, and I'm going to be taking care of you for the next 6, 8, however many weeks, and I'm here for you, and I'm part of your care team. So the simulation education kind of varies. So My particular physicians do a lot of brain and spine treatments, so I will go on with that. So you can see kind of in this photo up here, this is how we do. This is our simulation therapist, Olivia. She's fantastic. This is one of our staff members, just for purposes of showing this. But so this is the mask that we make for radiation therapy, and the head mold that goes underneath, that is used to keep the head still every single day for positioning. It's tight fitting. It starts off warm and flat. We stretch it over the face, and it kind of just holds your head and chin in position for that treatment every day. Some important things to know for a lot of these kids that are getting brain and spine radiation is that they're also going to get about 6 tattoos. And tattoos are just that. So they are, we have a little tattoo machine that adds little dots to the skin. They are permanent. But as you can imagine, a lot of these kids are very young. They're not going to get them touched up like you would a recreational tattoo if you have any. So they do fade over time, but they are permanent. And that can be a stressor for kids that are old enough to understand, and especially for families thinking about tattooing their children. But it's really helpful for setup and kind of staying in that right position every day. We also have to let them know if they're having brain and spine treatment, and this is important particularly with sedated kids, that they're not going to have anything on under their gown. So they do have to be exposed, no underwear. They do have a gown on, but we think that's really particularly important to let families know, because if the kid is sedated and unable to speak for themselves, we want the parents to know on the front end and not on the back end that they were not able to have underwear on while their spine was treated. And so as you can see on this bottom picture right here, this is what a treatment table looks like. So you can imagine the longer you have to lay there, the more uncomfortable it is. So we do a lot of just kind of showing them kind of what that will look like to kind of assess what needs they might have during that process. Skincare education is very, very important. So depending on how close radiation beams are to the skin, it can cause different degrees of skin irritation, redness, darkening, peeling, things like that. It runs the gamut from no radiation dermatitis reaction to full open wounds that we have to take care of. So we kind of start assessing that and assessing where the beam paths will be from the very beginning, because nursing handles the skincare of patients. We give most of our kids a cream called Sonofin cream. It's the same as Biofin cream, if anyone has heard of that, for some prevention, but sometimes it's just not enough and we have to escalate from there. And then on consultation day, of course, is the day that the physician has the conversation with the patient and family about radiation being part of their treatment course, what that's going to look like, what the side effects are, and we get our consent. So our treatment consent, we think it's very important to tell the families. This gives us permission to continue, and it allows us to treat you, but it doesn't bind you to treatment here. It's not a contract, it's just consent, it's just permission. So these conversations can oftentimes be very hard, because radiation, while necessary, is not a trivial treatment, and it can also cause, a lot of issues down the line. So you want to make sure that you're giving your family as much time and attention as they need to ask the questions and to really be present for anything that they might have and anything they might need. So after the consultation and simulation process, it's time to even dive a little bit deeper. So like I said, from that simulation, it takes about a week to a week and a half to be ready to start radiation therapy. So a plan is usually approved by the radiation oncologist, dosimetry, and physics sometime early in the week, the next week. So if they simulate on a Friday, I might know the next Wednesday that they can start by the next Friday, for example. So the nurse will go ahead and call the family and just say, hey, this is your tentative start date, your completion date. If there's any alternative treatment days, for example, this week here is Thanksgiving, and so we treat Sunday through Wednesday and take Thursday and Friday off. There are various times like that kind of through the year, and so we make sure that if they come against any of that, we go ahead and prepare them for that and tell them what those weeks will look like, and also give them their best chance of kind of going home for any holidays if possible. And then we also kind of reiterate that skincare and symptom management education. So if there's any chance that you're going to be nauseous, we go ahead and kind of say, hey, go ahead and start taking your nausea medicine 3 times a day on this day, and things like that. And then, of course, we go ahead and check, because the consultation is long and it's a lot of information in one day. We go ahead and touch base and see if they have any questions or needs before they actually get started with treatment. Okay. So, of course, radiation is a collaborative process. A lot of people have kind of a hand in the treatment process. And so this is really important for us to let patients and families know how many people are on their team to make radiation the safest and most effective treatment that it can be for them. So we have our physician, or our DO, so that's just the radiation oncologist, who, of course, goes over all of the radiation, plans it, kind of maps out what they want treated. We have our nurses who put in all the orders, kind of make the nursing decisions, take care of the side effects, skin care, all of the behind the scenes things. We have our radiation therapists, who are the ones who actually deliver the radiation, physics and dosimetrists, who help with the radiation oncology plans, make sure they're safe, see what critical structures can possibly be missed, and help kind of carry out that treatment as well. For those patients that need anesthesia, we have our anesthesia team. So anesthesiologists, CRNAs, and our RO peri-anesthesia team, which is a group of anesthesia nurses who work just on like the pre-anesthesia and post-anesthesia side of radiation care. And then we have our child life specialists, who, like I said, are very, very important down here. They're very special trained people that kind of help us go in at a child's age level and help explain and really help their experience be the best that it can be. So once a patient gets started with radiation therapy, we kind of check in with them during treatment. So for every 5 treatment days, our patients will have a on-therapy visit with a physician and a nurse. That is to touch base at least once in a treatment week to see how is their nausea, how is their skin, are they having any issues, for any focused assessments. So checking neurological status, checking to see if weakness is worse, improved, anything like that. The dermatitis assessment. So we kind of just see if they're having any of that breakdown, if they're having any symptoms related to that. Do we need to increase creams, add dressings? Do we need to maybe take a few days off of radiation if feasible to kind of give that skin some time to heal? And then during treatment management, if the patient is having any issues on the treatment table, nausea, anxiety, anything like that, the nurse intervenes and medicates if necessary. So if there's someone who's very claustrophobic but doesn't necessarily need sedation, we give them Ativan or something like that to kind of help them relax and be able to get that safe and effective treatment in the best and least invasive way that we can. And then in certain situations, we have patients that we need to stay at the treatment machine while they're treated during their actual treatment process. So this is kids that are feeling sick, just in case we need to run in, take a mask off, and let them sit up if we think that there's a chance that they may vomit, to avoid aspiration. So things like that. And then the continuing education pertaining to treatment. So like I said, the nurses in our area it's a lot of education. It's a lot of, this is what that's going to look like, and this is what this means for you, and do you have any questions regarding that? Okay, so when they're wrapping up radiation therapy, so when they're in their last kind of handful of treatments, We do discharge teaching, so a lot of that includes continue using your skincare for up to a week, continue nausea medicine for 2 weeks, use sunscreen forever and ever. Sunscreen is super important, but it's extra important for you because you've had radiation to these areas. And then just kind of our phone numbers, our names to the clinic, things like that, so that if they have any concerns, they feel like they can reach us at any time. We go ahead and discuss their follow-up plans. So most of the time we'll see our kids that have had radiation at least one time when they are done, just to kind of touch base. Hey, how are you? Do you have any issues? Do you have any questions? Is there anything after radiation completed that you had any questions about? Things like that. And then we answer any pending questions before they go home. So now that I've had radiation, can I ride a roller coaster? Can I drive a car? Can I do things like that? A lot of that is asked kind of in this wrapping up radiation time point. Okay, so the next phase after they are done with radiation is our follow-up phase. So when they come back, they've had radiation, and they kind of come back for that visit that we discussed at the very end. So the nurses are responsible for ordering all of those follow-up visits. So when they're done, we order that follow-up based on physician direction or protocol requirements. So like I said, a lot of physicians, they'll usually see them at least one time. So that's pretty standard. They want to see them at least one time when it's done. Hey, you were done about 4 or 6 weeks ago. How are you? What does it look like? Are you okay? And then some requirements or some protocol requirements are that we bring them back actually a little bit more frequently. So we have a protocol that we had here for a little bit that follows kids that get proton therapy. And we see them once a year to kind of see what their side effects look like and things like that. So those are things we have to pay attention to when we're ordering the follow-up for these patients. And then when they do come back for follow-up, we do need to look at those protocol follow-ups because sometimes they have research questionnaires and post-radiation symptom management that we have to take care of when they're here. And then the nurse requests imaging and records from follow-up visits done for the patient locally to upload for comparison in our St. Jude system. So if they had a scan intermediately at home, we call the hospital where they had their scan. We have it pushed to our facility so that our physicians can review that as well, so that there's a big collaborative effort in the patient's care. Okay, so during our follow-up visits, we do that post-RT patient assessment, kind of how I mentioned before, just seeing how they're doing. We go ahead and do those measurements and forms, and then we have observation of intermediate to long-term post-radiation side effects. So if you're told during your radiation consultation that as the years go by, you might have learning deficits, things like that, we make sure that they get a neuropsychology consult. And they have that testing done so that they can get help via IEPs or 504 plans at school to kind of help meet their needs because they are a previously radiated patient. And then side effect management, if indicated. Some side effects can last for a while, some don't. But we just kind of take those opportunities to see if there's anything else we need to do. And then yet again, continued education. Okay, so I just wanted to kind of go through some of the additional responsibilities we have behind the scenes. I kind of joke with my colleagues sometimes that a radiation oncology nurse, although we're with patients all day, a huge part of our job is just behind the scenes. And you're kind of able to see that through some of the things that we do before we ever even see the patient, meet the patient, or know the very first thing beyond their name and diagnosis from the very beginning. So some of the additional things that we do completely behind the scenes is obtain operative reports if needed. And that starts, I talked about it a little bit at the beginning when we're having an MRI scan. If they've had a surgical procedure and have any type of implant, we need that. But also once they leave us after they've had radiation, if they have any operations that they could have needed because of a complication of radiation, we need that. We need those records and we need them in their charts so that we can help them. Kind of with that moving forward. We keep up with patient communications and messages. We have a whole message center in our charting system where patients can send us messages all day long, 24 hours a day. Of course, we only answer them kind of during business hours, but we do have to keep up with those messages, and we answer on the upwards of 50 or so a day. We upload scans and submit pathology for review. So if a patient goes home and has a surgery for a metastatic spot, anything like that, we kind of get those things taken care of and submitted to who they need to be submitted for. We optimize clinic schedules for our doctors. So we will look, and if it's really heavy in the morning and really not heavy in the afternoon, we kind of go through and shuffle things around to kind of make the clinic flow as efficiently and easy as it can, while also allowing us to give that adequate time for patients and their families and things like that. Outside care coordination. So if they're needing anything at home locally, so if radiation 5 years ago caused them to have a growth hormone deficiency, we help find them a endocrinologist locally who can kind of help take care of those things a little bit better than we can. And it's also more convenient for them to be able to see those people locally than to come all the way to St. Jude just to get that issue taken care of. Any type of record retrieval. We schedule hyperbaric oxygen if a kid has necrosis and kind of needs that extra care, or if they have wounds that really need hyperbaric oxygen for healing. We have a hyperbaric oxygen treatment center right down the street, which is very convenient. So we contact them and schedule those things if needed. We help with protocol consent and data collection. So if they're going to be on a protocol that involves their radiation care, we go ahead and do that consent process, and we just kind of help collect any data around that. And then any protocol stimulation testing. So we do for certain patients growth hormone stimulation tests, which take about 4 hours and things like that. So that's just some other things that we take care of completely behind the scenes to kind of help our patients. Okay, so I will open up the floor for any questions.
Yeah, thank you very much. That was wonderful and powerful. So we need to go and join